Okay, we'd like to welcome everyone to the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for June 19, 2020. It's a pleasure to have everyone here. This is Adventures in Neuro-Oncologic Diagnostic Medicine. We always start with a warm-up because you can't just jump right in, so let's do that. And I think for today, let's start with a CT warm-up. What is your diagnosis? I'm going to give you a few seconds here to think about this and study the image all three planes. Okay, lobar hemorrhage. Let's just go with that. I don't think that you could know specifically what the etiology is, but this is what I'm looking for, is a big hemorrhage in the right frontal lobe. All right, within that, what is your differential diagnosis? Just think, what are the different causes of lobar hemorrhage that you can think of? Let me just give a second here. Thinking. Yes, Andrew Gilbert actually got it. Let's see, Darshan Trivedi, amyloid, good guess, exactly. All right, here's what I came up with. Ruptured vascular malformation, amyloid angiopathy, hypertensive hemorrhage, not the most common location, but sure, it absolutely happens in the frontal lobe. Thrombocytopenic bleed. This could be an immunosuppressed patient, chemotherapy patient. Hemorrhagic metastasis, hemorrhagic primary tumor. All right, now, based on the next CT image, what is number one on your differential diagnosis list? You know, a lot of times in this conference, I will ask you, what's your diagnosis? Like everything is pathognomonic, and I know everything is not pathognomonic, but the point is, based on all the data you have, what I'm asking is, what is number one on your differential diagnosis list? And I'm just going to go ahead and ask you straight out, what is your diagnosis based on the next CT image? All right, everyone ready to play? Feel free to use the chat function. All right, here we go. What's your diagnosis? What is the cause? What is the etiology of this lobar hemorrhage? And of course, you would have to justify it if we were live. If we were in the conference, you know, with the old conference on Thursday morning, and you got the answer correct, I would say, yes, you're correct. Why? Anyone want to chat? I'm not seeing any chats popping up. All right, doesn't happen soon. I'm going to, yes, Andrew Gilbert, gyriform calcification. That is exactly correct. This was the key. Gyriform calcification. Yes, Dr. Harb, oligodendroglioma in the context of a lobar hemorrhage with gyriform calcification. Notice that this lobar hemorrhage is going to mess up essentially everything on the MR scan, right? Because all the architecture, all the pride is going to be destroyed, but not the calcification, which is beautifully seen on the CT. Second best would probably be on MR, gradient echo, T2 star. All right, but that's basically it. Here's the histology. Guess what? Oligodendroglioma. In fact, it was anaplastic oligodendroglioma because of the vascular proliferation. Here's the point. What are the most common primary brain tumors that present as a lobar hemorrhage that don't declare themselves right up front? The answer would be actually glioblastoma number one, just because it is so common. It is certainly not a very common presentation of glioblastoma, but it does happen. I have many examples that I could show at this conference. However, oligodendroglioma, particularly really anaplastic oligodendroglioma, where you have the vascular proliferation, which appears to be labile, this is actually a common presentation of anaplastic oligodendroglioma that you need to be aware of. And of course, Dr. Andrea Gilbert, neuropathologist, UT San Antonio, was all over this one. She guessed it just from the lobar hemorrhage. Now, Dr. Gilbert is doing a little bit of gamesmanship. Being an oncologic neuropathologist herself, she anticipated that I was going to set some kind of a trap. And of course it was. All right, here's the final diagnosis. Anaplastic oligodendroglioma, IDH mutant and 1p19q co-deleted WHO grade 3, and that is the WHO 2016 diagnosis, and we're using the Arabic numbers, which the C-Impact Committee has certified, and which we will be switching to with the 5th edition of the upcoming World Health Organization. You can see from the details, IDH, it was actually a non-canonical IDH2 R172K mutation. All right, good job on that one. All right, let's try MRI. MRI, instant pattern recognition. All right, you ready for this? We're still warming up. I want someone, just feel free again, use the chat function, or you don't have to, but it helps me to be able to make comments. This is an instant pathologic recognition. Now, I'm going to make this point in just a second, that actually what is an instant pattern recognition varies depending on the person. If you're a medical student, typical medical student taking a pathology rotation, if you're a first-year general pathology resident, this is not probably an IPR. If you're in the business, if you're a neuro-oncologic physician in any of the disciplines, it still might not be an IPR. But if you are an oncologic neuroradiologist or an oncologic neuropathologist, this is essentially an IPR. Now, is it pathognomonic? No, there is always a differential diagnosis, but there is one entity. Here's my point. There is one entity when you see this image that should be right at the top of your list, and it's going to be that entity until proven otherwise. And of course, you're going to have choice number 2, choice number 3, et cetera, and then you will continue to add the Venn diagram data spheres until you get the precise diagnosis. Okay, everyone ready to play? I just want to know, what is the most likely diagnosis based on the imaging morphology? Imaging morphology works exactly like pathology morphology. Same. Okay, everybody ready to play? Here we go. What's your diagnosis? I'm gonna give it here. Just I'm sure we have easily 10 or 15 seconds to spare. So I'm going to type in, what is number 1 on your differential diagnosis list based on the imaging morphology? All right, Dr. Harb came close. I will show you why. Dr. Harb, there's something better, and this comes with experience. It comes with knowledge. Do we have any neuroradiologists? Yes, Michael Evans. Absolutely, Michael Evans nailed it. I'm not going to give it just yet because I have a little bit more to say. Michael Evans is a radiologist. He's a graduating fellow. He is an excellent neuroradiologist, and he nailed it. Now, the reason why I'm telling everyone that is to say that there are people in this audience, and Michael Evans, Dr. Evans does not know this case. He's looking at it. He's looking at the shape. This is a cellular supracellular mass, but all cellular supracellular masses are not the same. And this one on the sagittal, T1, with or without contrast, it is very distinctive. All right. Here's my first point. If you said pituitary adenoma for this morphology, and I will agree with you that pituitary adenoma absolutely is in the differential diagnosis, but this is not the shape that 99.9% of pituitary adenomas grow when they come out of the cella, through the diaphragma cella into the supracellular cistern. Why would they make a rostral turn and start heading upstream instead of just expanding straight up and compressing the optic chiasm like they're supposed to do? The ice cream cone sign, the snowman sign. This is not a snowman, an inebriated snowman maybe. All right, that should give you pause before you go with that. Okay, you ready? Okay, if you said pituitary adenoma, you are not quite yet ready to bear the title of oncologic neuropathologist. You need a little more experience. Okay, would you like to see 6 cases, this case plus 5 other cases of exactly the same entity with a sagittal T1 with contrast to help convince you that what I'm saying is number 1 should be number 1? Well, here they are. These are six MD Anderson Cancer Center patients with exactly the same tissue-proven diagnosis. And I'm going to give you a second here just to study each one of them. Have a look at those. Do you see how reproducible this picture is? These are 6 cases of the same entity. I mean, that's striking. Okay, for anyone who's, I don't know, we may have some medical students tuning in that still don't see the abnormality. This is what we're talking about. It is stunning how similar all of these look. And they look so similar because their epicenter, where they start, which is not in the cella, and how they grow, which is anterior and posterior, is highly reproducible. They grow the same in each direction. They grow rostrally towards the sphenoid planodale, the sphenoid planodale, and they go posteriorly into the septum. All right, this is a tuberculum celomeningioma. It's starting right at the meninges over the tuberculum. Go forward into the planum sphenoidale, All right, and that's where you see the nice dural tail, and then they grow posteriorly and usually dip to varying degrees into the sella. Now, here's the key. Listen, here is the key. Look at this rostral dural tail. It's never caudal. You're not going to see the dural tail in the sella, and they're not going to fill up the sella and then start heading down the clivus. That would be very, very unusual. I'm not sure I've ever seen that. It doesn't mean anything. But look at that dural tail rostrally. This is not what pituitary adenomas do normally. I'm sure there's an exception somewhere. Small pituitary macroadenoma mimicking a tuberculum meningioma, but I don't think so. Okay, I got to thinking about this. Let's go back. Let's look at all 6 of these panels. They're so reproducible. I got to thinking, what does that shape look like? You know, I'm going to create a new imaging sign for the appearance of tuberculum sella meningioma on a mid-sagittal section. And I got to think, well, it looks a little bit like a dolphin maybe, but the dolphin, bottlenose dolphin, that's pretty close. But I think as biologists, and, you know, my degree was zoology, all right? And as a zoologist, you know, I know about these things. So I think it's the echidna. I think that's what we're talking about here. But, you know, all echidnas are not the same. Can you kind of see what I'm talking about here? Actually, all the echidnas that you're seeing here are not just echidnas. These are long-beaked echidnas, all right? Long-beaked echidnas. And of all the images in the Google search that I looked at, I think I actually like this drawing the best. And this comes from www.supercoloring.com pages. And for free, you can print off these pictures of all these different types of echidnas, and your kids can color them in. All right, so this is the Western Long-Beaked Echidna, and I think that's what this meningioma looks like. So I'm going to call this the Western Long-Beaked Echidna imaging sign for tuberculum sella meningioma. Now, I think of all the images of all the cases that we've had in my small collection of MD Anderson, I think this is the one that most closely mimics pituitary adenoma, because it looks almost just like the snow cone or the snowman sign with a little bit of a waist, right? But if you look detail is so important to radiologists and to pathologists. If you look at the detail right there at the tip of the arrow, that's a dural tail, you know, that's going to be the beak. So I will call this the baby Western Long-Beaked Echidna sign for small tuberculum sella meningiomas. You like that? All right. Full disclosure, no echidnas were harmed in the coining of this now classic imaging sign. You know, I would not do that. I protect the echidnas. Okay, let's move on. Genomic alteration IPR. Are you ready for this? Genomic alteration IPR. I want to know, you can just give me the diagnosis or the genomic alteration. It's all the same. Here we go. What is it? What's the genomic alteration? What is the diagnosis? I'll accept either and give just a few more seconds. I know many people in the audience know this. All right, yes. All right, I got three in a row. Yep, absolutely. Dr. Harb, IDH mutant diffuse astrocytoma. All right, good job, Dr. Evans. Good job, Dr. Gilbert. All right, exactly right. What we're seeing here is the T2 flare mismatch sign, all right, of diffuse astrocytoma IDH mutant. Now look, have a look at this. Here's the point. The image on your left, all right, this is a right temporal lobe diffuse astrocytoma IDH mutant. The image on your left is the T2 flare. The image on the right is the native T2. If you compare the T2 flare with the T2, there is a darkening, all right, of the center of the lesion. Now, I particularly chose this example because it is one of the more subtle. And you could scroll up and down, all right, for 2 or 3 cuts, all right, up superior and inferior, and you would see slight variations of exactly the same thing with the maintenance of that hyperintense rim, but suppression of the center, okay? It is enough because in a negative T2 flare mismatch sign, the intensity is the same on the T2 flare. It is not diminished one iota. After you control for maybe hemorrhage or calcium or anything else that might be there, you do not have these zones of even this subtle hypointensity. This is not that subtle. Now, the reason why I wanted to present this is because it actually came up at Tumor Board, and I like to present things that are current, right? And the question is, to the trained eye, you look at this, it's like, bam, done. That is T2 flare mismatch. And by the way, this is a tissue-proven diffuse astrocytoma IDH mutant with a history. I think this one was maybe 5-6 years down the road, and we're looking at a scan way in the past. And if we had known now if we had known then what we know now, this would have been slam dunk. Okay, good job. Good job, everyone. I'm going to keep presenting this until everyone knows about it. And look, everyone that's listening to this conference, you have to be ambassadors spreading this knowledge, all right, about the T2 flare mismatch and all of that stuff. That's your job, because it is still not well known out in the community. All right, there you go. Okay, how about a histology warm up? I think I've gotten into the habit. I think it's a good habit of warming everything up. Right, we're going to warm up imaging. We're going to warm up genomic signatures, and of course, we're going to warm up histology. All right, here's the question. I'm going to show you a histologic image, an H&E, to be specific. This is the question for you. From looking at this one panel, single image, single field, about medium power H&E, what does the pre-op CT imaging show? Got the question? Ready? Let's go. Here's the panel. The question is, what does the pre-op imaging show? Now, in order to answer that question, you're going to have to put puzzle pieces together. I'm not going to show you a pseudomonas meningioma. Oh my goodness, that's not even kindergarten, that's pre-K, right? For this audience. You're going to have to put several puzzle pieces together to get the most detailed response to my question. And when I say, what does it show? All right, I'm asking, okay, good job, Dr. Gilbert, pretty good. I want to be a little bit more precise. So look closer, Dr. Gilbert. There are at least 3 or 4 major findings. The neoplasm is the most obvious, all right, and yada, yada. It's the other things after you've gotten past this epithelioid neoplasm. That's just the baby starting point, right? Now, this is to emphasize detail. And there's actually, even more for that. Dr. Harp, hemorrhage. Okay, there's another puzzle piece. So I'm getting puzzle pieces. So I've gotten that there's going to be a mass some area. I've got that there's going to be hemorrhage. Can you nail it down? How about this? What if I were to ask you the question, what if I were to tell the story? Now, for those of you in the audience who were regular participants at the pre-COVID Thursday morning Integrative Diagnostic Medicine case conference, I had a thing, a little set piece that I would run called Tell the Story. I would show one image, and the idea was I'd ask for a volunteer in the room to tell the patient's story, a plausible story based on the data. You have to justify it. You could tell a very plausible story, the entire story, not just what the CT image looked like, but based on what the CT image looked like and all of that, you could tell the story of the patient. Now, is that amazing, anyone? All right, that is the level of detail that I want from you at this conference, both for the imaging study. The imaging studies can be radiologic imaging studies. They can be histologic imaging studies. Okay, look, let's walk through this. Let's walk through the case. This is going to be, how does an oncologic neuropathologist look at this single field? All right, let's do it. First question, always, it's intuitive. What is the tissue trying to tell me? And if all you want out of it is pseudomonas meningioma and go home, play golf, CrossFit, whatever it is you do, all right, that's not enough. There's always more. There is always more in the slide. All right, here we go. Densely cellular epithelial, that is the most obvious. All right, that is a given. Yes, it's epithelial. Everyone sees, speaking to the neuro, and we have very sophisticated neuroradiologists. All right, many of the neuroradiologists probably looked at this and said, "Oh, I can see the cell borders really well. That's epithelioid." I'm thinking of all the epithelioid tumors that I can think of. Epithelioid glioblastoma. There's a good one, right? Epithelioid. It could be a melanoma. It could be ATRT, be epithelioid. It could be epithelioid carcinoma. Carcinomas from virtually any epithelial surface can be epithelial. I think breast is probably one of the most common that we see, really purely like disjointed, disheesive epithelial. Okay, et cetera, et cetera. All right. Okay, what else? It's in the cerebellum. Now that was the key. Can you look at this image and see the cerebellum? All right, that is one of the first things that I do. There's a game that all pathologists play. It starts in training and it continues throughout your entire career. And we play this game with the outside cases, the cases coming in when we don't have huge pressure, unless the patient's actually in the clinic, we have to move faster. But the game that we play is we don't look at any information, nothing. I don't want to know the name. I don't want to know the age of the patient. I don't want to know the gender. I don't want to look at the label on the slide, even if it's all H&Es. I don't want to look at the label because the label might say something like SO34692. That just told me that's a 2003 surgical specimen. That convention is used almost all over the world. I don't want to know that we're 17 years out. That's giving me chronicity. It's giving me all this information. So I will look at that slide initially, and here's how it is. What you do is you try to get as far as you can go in reconstructing everything from the H&Es. That's what you do first. Then you look at the immunostains, and if they're molecular surrogate immunostains, you look at those differentiation marker and molecular surrogate. Then you look at the imaging, and then the very last thing you do is look at the outside pathology report. Now remember, the outside pathology report's 8%. Let's just call them 10%. 10% are wrong, or at least we'll have at least one piece of information or one statement about an immunostain or this or that is just flat wrong. Why would you start by looking at wrong information? That is idiotic. So you see as far as you can get. All right, cerebellum. This is cerebellum right there to your left, to the eye that's looking for it. You need to look for it. All right, there's a leptomeninges. See that smooth outer layer? It's got blood vessels, few little inflammatory cells. Then the molecular layer. See how it looks like neuropil? It looks like that's a neuropil. You know, we're in the brain. Then there's a thin layer, a thin little line of the right here. I think if you can see that marker, I don't know if you can see it. These are Bergman astrocytes all along here, a little thin layer. Okay, where are the Purkinje cells? The Purkinje cells are gone. They're long gone. Purkinje cells are exquisitely sensitive to ischemia. They will disappear when you've got a big tumor next door. And the big tumor can be metastatic tumor, a metastatic carcinoma. It can be hemangioblastoma in the cerebellum. The local Purkinje cells that are out of town. But the granular cell neurons, look deeper. See the granular cell layer? All these little guys? Can you see how it's forming a layer? Do you see those anywhere else? Here in the, no. That is the granular cell layer. That is saying cerebellum. How cool is that? All right. Hemorrhagic, possibly melanotic. All right, very good. All right, I think Dr. Harb got this one. If you look up here, way up here, upper left corner, that's a subarachnoid space. Clearly, that's a lot of blood. Now, you could say, you know, that could be just operative blood from the current procedure. Yes, of course, it could be. But anytime you see it, you're going to look for hemosiderin. You'll look for reactive gliosis. You'll look for signs that it's real, correct? And then the other thing, look in the highlight square here, all that faint brown pigment. Do you see that? If you hadn't seen it before, here, let's go back. Can you see it now? Did you see it before? Hopefully you did. I mean, it is absolutely there, and that should raise a suspicion. What is that pigment? It's either hemosiderin or melanin. The odds are. And by the way, there's more at this little vessel. All right here. There's a little bit in the wall of that vessel. Okay. All right. Let's keep going. So there we go. All right. Here's the thought process. We've got this bleed. It's a bleed. That's why he's asking what the pre-op CT showed. Why did I ask you what the CT showed? All right, this was not a CT warm-up. This was a histology warm-up. Why did I ask you about the CT and not the MRI? And not the MRI because, you know, or just imaging. I could have said, what is the imaging? That was a clue that I asked specifically for CT. Immediately, you should have been thinking blood or calcium. I mean, those are two big things, blood, calcium, or bone abnormality, right? See, that's what the thinking mind, right, would address that. You're always looking for clues in every arena. Probably an emergency CT followed immediately by surgery to prevent lethal herniation, because now I know I have a hemorrhagic epithelioid neoplasm in the cerebellum. Look, the cerebellum's in the posterior fossa. For those who are a little rusty on their neuroanatomy, the posterior fossa is a tight space, all right, bony enclosed, all right, with a lot of critical structures. The brainstem being the big thing, and all of those nuclei for cardiorespiratory control. And when there's a big mass expanding rapidly of blood, the brain's going to have to squirt out the top, all right, upward transitorial herniation, or down the bottom to the foramen magnum, and they are both tonsil hernia. They are both bad, all right? How about, since it's epithelioid and there may be pigment and it's hemorrhagic, how about metastatic melanoma to the cerebellum with hemorrhage, a surgical emergency? That is the story that I was looking for, attention to detail. Now, I know you can say, and it's fair, you can say, no, wait a minute, I didn't actually have the H&E, so I could scan around. No, you didn't. And you didn't have the path report either, right? And that's really what you're asking for. What you really want is just the answer, right? Yeah, I'm being sarcastic. Life is not going to give you big, beautiful tissue sections. What you're looking at right now, with the magnification also, with those limitations, that will be all you'll get in a tiny fragmented stereotactic, hemorrhagic stereotactic biopsy sometimes. And you're going to have to recognize cerebellar tissue, meninges, peripheral nerve. All of these clues can help you tremendously. Lipofuscin in a large projection class neuron tells you you're in the brain because that is a neuron and it's surrounded by tumor. That's important. A corpus amylation, right? A polyglucosan body and an astrocyte process. You see a corpus amylation, you're in neural tissue, brain or spinal cord. You're not in the meninges. That can be huge, right? You everyone understand? This is important stuff. All right, here's the imaging. There it is. Hemorrhagic mass, big hemorrhagic mass in the cerebellum. This is metastatic melanoma. That bled in the posterior fossa. Quick CT. CT is a lot quicker than MRI. Quick CT, yeah, it's a bleed to the OR, decompress, save the patient's life. You like it? Okay. That was actually a little too easy, honestly. I'll be candid with you. And so, see, at this conference, what I try to do is I try every time to provide challenges at every level. So occasionally, I will put in a pseudomonas meningioma. So everyone gets a participation trophy. You are number one, a blue ribbon. All right, but I also have to keep those at the highest level interested, right? So there has to be at least one case. Okay, so I'm going to call this, we're going to do another histology IPR. I'll call this Genius Edition. Because you got to be pretty good to get this, right? And you're probably going to have to be an oncologic neuropathologist. It's going to be pretty tough for the oncologic neuroradiologist unless they've attended most of my presentations, the grand rounds and the yada, yada, yada. Okay, you want to give it a try? Is it interesting? All right, and again, this is what I actually said earlier. I kind of jumped the gun. What constitutes an IPR is a function of knowledge base and experience base. So what is an instant pattern recognition? I mean, one look, you got it. That's going to be a lot different from a first-year pathology resident than a tenured, full professor has spent, 40 years in the field of oncologic neuroradiology, oncologic neuropathology. All right, so I'm aiming up at the upper end here and maybe a precocious few. All right, ready? Okay, now I'm not just going to give you one field like the last one. I'm going to show you about four fields, H&E fields of this process and this lesion. We'll call it a lesion. I want you to take each one in. So have a look at this. What you're doing, you're gestalting the whole thing. That's number one, gestalt the overall, the big view. Then you're going to get down granular, look at the cells, look at the nuclei, shape, size, etc. Look at the cytoplasm, whatever you might be able to tell about cytoplasm. Are there clarified egg areas? Are there spindle areas? Are you eosinophilic? Yada, yada. You look at the vasculature. What's the vascular to? Is there vascular proliferation? Is there not? The pattern, etc. Here's another field. This is slightly different. Again, you're looking at the overall gestalt. Look at the nuclei. Look at the cytoplasm. Just take a minute, take it all in. Look at architecture. What are the different constituents doing together? What's the relationship of the cells with the blood vessel? And you're turning all this over. It should be, your mind should be like a tumbler that's spinning these differential diagnoses, and they're continuing to shuffle the list. Imagine a vertical list of all the differential diagnoses, and as you get more data, you're getting new data with each histologic panel, you're reshuffling the differential diagnoses and trying to figure out what's on top. Here's another panel. What I'm hoping is as a pathologist, when you look at this, the first thing you think of is, oh, this is interesting. Why? It's interesting because there's definitely pattern. There's patterning going on here. It is interesting. I'm looking at the vessels. I'm looking at the cells, what they're doing. Now, it's not classic. This is not a 101, right? It's not a kindergarten or a pre-K IPR. It's a sophisticated IPR. And actually, I've given you a huge hint just by telling you that. You're looking for something special when you have put all this together. And you got you're gonna have to put it together. You like gonna? I'll use gonna. You're gonna have to put it all together. All right. This is. I think this is. I've got one more panel after this. But again, what you're looking at, cells, etc. The vasculature. I know. I'm throwing down hints, but it's like still I'm being very gracious. Now you're putting all these things together, and if you're what they call it a one-trick horse, if you only have one thing. Like I see a Samoa body, meningioma. I see pigment, melanoma. If that's all you have, you're going to be in trouble when you encounter a tumor that has several of these. Then which one do you give precedence to? Which one do you give the most weight to? Well, if there's no scientific data saying that one is superior to the other in predicting, with the diagnosis, with the prognosis, and molecular signature, then you're probably going to be human. You're going to be frail, you're going to be weak, and you're going to overweight a single criterion and arrive at the wrong diagnosis, being simplistic. All right. And this is the last image I'm going to show you. It's giving some features, actually 2 features that you've not seen before on any of the others. Give you a second to take that in. 2 features not seen before, and they're very closely related. Okay. That is the lesion proper, but there's one more thing. I'm going to show you just two more slides, 2 more H&E slides, kind of different. All right. These will be the last 2. Here's the first one. Take that in for a second. Anything interesting? Here's the second. This is a different field. There's a big similarity between the 2. All right. Okay. I'm sorry. Dr. Harb just said something. I was focusing on the big screen. Dr. Harb's probably correct. It's been my experience. All right. Let's start with these last 2. All right. We're going to start there first. Here we go. What are these 2 slides telling us? What are they? They're telling us something very special. Yes, Darshan Trivedi, this is a pseudoepithelial lining. All right, this is what you're seeing. Dr. Gilbert says the lesion is cystic. Yes, probably a big cyst. This is a long epithelial lining for a microscopic slide. I mean, these are long, and that's vascular proliferation. That's just deep to that smooth lining. So it's probably going to be an enhancing lining on the T1 contrast. All right. So it's going to be, it has a big cyst. Now that's informative. Now, how do you recognize that? Maybe for the neuroradiologist, it's not just so intuitive. When we're looking at tissue fragments, you can see natural boundaries. This would be like, say, the molecular layer, the PIA, at the surface of the cortex, surface of the cerebellum. You can see sharp cuts, which would scalpel cuts, which would either from the surgeon or more from the pathologist when we cut squares of tissue and put them in the blocks. You see other natural boundaries. This looks like a natural surface. It's smooth, and we're trying to figure out what it is. And what you see beneath it is just parenchyma. In this case, it's vascular proliferation, and there may be some tumor, etc. But it's a very smooth lining, and that is formed by compression from the cyst contents. That's where that comes from. And we as pathologists learn to recognize that in small morcellated fragments and put it together like assembling the puzzle pieces. Remember that old TV series Numbers? They did all the time assembling the puzzle pieces. Breaking Bad, you remember with the plate gets broken, puts the puzzle pieces together, saved his life. Remember that? All right, I'm not recommending Breaking Bad. Okay, here we go. Pseudoepithelial lining. That is what it tells us. How do you like this? You like that? Look at that. No one had to tell the oncologic neuropathologist that this was a big cystic lesion. We saw it in the tissue. We looked at the tissue, and the tissue said, this is what the pre-op imaging looks like. This is part of the pre-op imaging morphology. Now, this could have been a cystic meningioma. It could be a cystic schwannoma. In this case, it's a cystic intraaxial lesion. The pseudoepithelial lining looks the same no matter what the tumor. All right, that's an important lesson. Okay, so there it is. There's the lining. Wall of the lining, we're looking at it right there. How beautiful is that in terms of putting the pieces together? All right, and here's another cut sagittal. It's not purely cystic though. So this is not like pyogenic abscess or just an epithelial lesion. There is an irregular, sort of a bulky piece of disease posteriorly, and that is what we're looking here. All right, let's run through the slides. We're going to run through slides. I will narrate, and let's see if your thinking's like mine. The first thing I see when I look at this, it's definitely glial appearing. All of the tumor nuclei are very similar. The majority are round and monotonous. Some of them have halos. I definitely will entertain oligodendroglioma. Towards the right side of the field, they're looking a little bit spindly. All right, so they're not all regular round. And now I'm thinking, well, maybe not oligo because they're spindle, maybe astrocytoma. But I'm just thinking about it. Now here, dead center in the middle of the field, right here, if you see my cursor, and I'll try to mark it here with this fancy thing, that is a perivascular pseudorosette. The first thing you think of with that, number one on your differential diagnosis, if there's a lot of perivascular pseudorosettes, is ependymoma. And if they're wall-to-wall perivascular pseudorosettes with stout processes, you think astroblastoma. But this is not that. But still, that's a perivascular pseudorosette. It's not pathognomonic for anything, but it's another piece of the puzzle. Now, this is where it got interesting. You're thinking, what in the world are these, is going on? There are multiple perivascular pseudorosettes, poorly formed, if you will. The cells are kind of irregular, not so oligoid, more astrocytic-like, but that's an interesting pattern. All right, and now here, this is, that is what's so-called endocrinoi or chicken wire vasculature. That's what you're seeing, in the area all around here. All right, if you see my cursor, all right, all of this stuff down here, that is chicken wire vasculature, endocrinoid. All right, let's put this together if we can. So it's a big cystic lesion, fairly shortly circumscribed, surrounding modest vasogenic edema. And the features of the lesion itself are there are areas that look oligo, round regular nuclei with halos. There were calcifications, little calcifications in other areas. I will tell you that. I did not show them. In some areas, it's a more spindle morphology. That's another feature. And then the endocrinoid vasculature, that's one. And the perivascular pseudorosetting. So those are all the pieces. Guess what? It turns out that mixture of histologic features that I just enumerated is actually classic. It's classic for an entity. It's not always seen in the entity, but when you do see it, the first thing that should be on your list, or at least high on your list, that you need to rule out is this entity. And it goes all the way back to 2012, Science 2012, Transforming Fusions of FGFR intact genes in human glioblastoma. And right there, co-discoverer of this entity was our own Brittany Parker, all right? And Wei Zhang from formerly MD Anderson Cancer Center. The tumorigenic FGFR3 TAC3 gene fusion escapes, all right, the mirror microRNA regulation in glioblastoma. This is Dr. Parker Kerrigan, scientific manager, Department of Neurosurgery. She co-discovered this entity, and it was an amazing story. All right, then comes Brain Pathology 2017. Guess what? Diffuse gliomas with FGFR3 TAC3 fusion have characteristic histopathological and molecular features. We already knew about the molecular features. The big news here, what? Characteristic histopathological features? Are you kidding me? If you're an oncologic neuropathologist, do you think you might want to know about those so that you can already know what the molecular signature is, maybe, or suspected on the histology? Well, what are they? All right, this is from that paper. Well, monomorphous ovoid nuclei in the paper, they describe these as looking oligodendroglioma-like. Endocrinoid network of thin capillaries. Yes, we have that in the case we're looking at. Microcalcifications, I didn't show them, but I told you they were there. And then the nuclear palisading and pseudo-rosetting. That's a very poor example, in my humble opinion, on the far right of the perivascular pseudo-rosettes. Our case was even better. Let's look at our patient. Top panel. Yes, we had the oligo look. It's oligoid. It's not screaming classic oligodendroglioma. If it was, we would not be talking about this entity, right? But it's close enough. It's close enough so that your brain thinks maybe oligo, maybe oligo. All right. And then with the endocrinoid network, yeah, absolutely, that is there. And the perivascular pseudorosettes for sure. But those nuclei are definitely, again, not oligodendroglioma. But that is the pattern. And it's not illustrated in this figure from the paper, but in our case and in this original description, 2017 of the classic features, spindle cell areas is also a classic feature. And we had those. All right, what's the diagnosis? Here it is. Glioblastoma, IDH wild type, cystic subtype. Yes, I will put that in the diagnosis line. And then look with a big red box. FGFR3 TAC3 fusion positive. Now, how did I know it was glioblastoma? Well, the panel that I showed you had the vascular proliferation. How did I know it was IDH wild type from the H&E? Intravascular fibrin microthrombi. I'll show them to you again in just a second if you didn't catch it. That's why I showed you that last, the anti-penultimate slide before the pseudoepithelial lining. All right, from the histology, I got glioblastoma, I got IDH wild type, I got cystic subtype. I knew that was going to be the macroscopic morphology, and I had a strong suspicion from the histology that it was going to be an FGFR3 TAC3 fusion glioma. Let me tell you something. 3 times this has happened to me since this tumor was originally discovered by Dr. Parker Kerrigan and others. 3 times I have seen the characteristic constellation of features on H&E. I thought, I wonder if it could be. I emailed in 2 of those cases. I emailed the patient's neuro-oncologist who ordered Oncomine NGS profiling, and absolutely it was. It turned up on the fusion panel. Just wonder. And there's even more to the story than that, but it's for another time because we have to keep moving. I have more cases. Okay. All right. And then here was just from the top section is a comment of the report. H&E stain sections show a high-grade diffuse astrocytoma with elevated mitotic activity, vascular proliferation, intravascular fibrin microthrombi, which are highly associated with IDH wild-type genotype and necrosis, including foci pseudopalisade. Didn't show you those. Morphologic feature diagnosed with glioblastoma by classical histologic criteria. Areas of the tumor show a constellation of morphologic features: small, uniform, oligodendroglial-like in association with perivascular anuclear zones and intracrinoid vasculature, spindle cell foci that are characteristic of FGFR TAC fusion. And there are various FGR and TAC partners that can participate in that fusion. In addition, multiple fragments bear a pseudoepithelial lining indicative of a significant cystic component consistent with preoperative imaging studies. And there, the arrows are showing you the in the areas of vascular proliferation. That's a big curvilinear arcade of vascular proliferation, and you can see the intravascular fibrin microthrombi. Okay, and this is just going on to the next paragraph. Electrocyte was done, and then there I put in the histologic preference of the lining is predictive cystic glioblastoma, and I referenced Dr. Sawaya's former chair at Department of Neurosurgery and Indiana Cancer Center, wonderful paper on cystic glioblastoma, which is exactly what was visualized on pre-op imaging studies. That's all in my report, and that's a modern oncologic neuropathology report. Okay, is everybody warmed up? Okay, I got it. It's not quite a quarter till. I think we're ready to move on to patient 1. Okay, let's give it a try. All right, I'm going to show you images, and then I'm going to ask you some questions. All right, or I'm sorry, did I already ask a question? No, patient 1. Here we go. This is the MR imaging and clinical presentation. I'll just give you two sagittal cuts, almost a mid-sagittal, and just a very slight parasagittal cut on the right. Both T1 with contrast. Take a second, look where the lesion is. Assess, again, just like we did with the tuberculum cellum and angioma. Don't get sloppy. Look at the details of the lesion, all right? Okay, this is at presentation. This is 6 months later. Looks a little different, no? 6 months later, check out the 4th ventricle. In addition, this is 7 months later. That's a treatment catheter, some backwash. This is 9 months later. Isn't that interesting? Okay, you know what my question is going to be. Here it comes. What's your diagnosis? Clinical, I'm giving you 3 imaging time points. Clinical presentation, 6 months later, 9 months later. I want a diagnosis. There is more information that I have given you, if you have the eyes to see, than what I wrote on the slide. Michael Evans, Dr. Evans, just nailed it. All right, Dr. Evans, again, an excellent radiologist, neuroradiologist, just finishing our fellowship. Outstanding job, Dr. Evans. Perfect. Now, the reason why I'm singling out Dr. Evans for praise is I just want everyone to know, like the pathologists that are watching, that with enough knowledge, you can do this. All right. It's just knowledge and experience. All right. I'm going to give some help to the pathologist. I'm going to show you the histology. Here's a smear. I actually don't have the smear for this particular patient. I guarantee you the smear look the same. They all look the same. It's not a difficult diagnosis. So here's the smear. Yes, Dr. Gilbert nailed it. Absolutely. Yes, Dr. Alphatal nailed it. Absolutely. Okay, good job, good job. Let's go, we'll go up a little bit higher power. All right, what you're seeing is a biphasic. All right, biphasic. Dr. Gilbert says this was a radiosensitive a disease. Yes, absolutely, highest power. All right, what you're looking at are reactive lymphocytes. Dr. Harb got it, nailed it, excellent. Reactive lymphocytes in these large, ugly-looking tumor cells, biphasic distribution. All right, here's the tissue section. Honestly, which do you like better? Don't you like the smear better? I do. All right, and here's the immunostain. Any takers for the immunostain? I know that Dr. Gilbert and Dr. Harb and Dr. Alphatal all know it. Yes, Dr. Gilbert, that is correct. All right, yes, yes, very good, very good. Here we go, OCT34. OCT34 is the definitive, the signature immunostain of germinoma. All right, that is this interesting. It also could have been c-Kit. c-Kit's very sensitive, but it's not specific. OCT34 is specific. You like it? See the lymphocytes that are only hematoxylin? All right, here we go. Look, this was the information that you had to make the diagnosis. You knew from histology biphasic cell population. You knew the anatomic location, all right, from the pre-op imaging. You also knew the clinical history from the pre-op imaging because I gave you follow-up surveillance scans, which told you what happened. It got a lot worse, then it got a lot better after that treatment catheter was put in. I've just given you the natural history. I've just given you the clinical history, all right? And then there's the molecular signature. There's one other piece. Did we know the age of the patient? Did I give you the age of the patient? Yes or no? The answer is I gave you yes, Dr. Evans is correct. All right. I gave you the age of the patient in terms of morphology. Morphology. I'm not talking about diagnosis like, oh, you figured out that it was a germinoma. I'm talking about from the very first scan, did I give you? Yes, Dr. Gilbert. Dr. Gilbert got it. Here we go. Yes, it was in the first data slide. There's the age of the patient. That's the age of the patient right there. Right, this. What is that? That is the age. That's an unfused phenoexypical synchondrosis. It's unfused on both sides. It's a child. All right, do I know the birthday? No, I don't know the birthday, but I know this is a child probably younger than 10 years old. That's how I knew. That was a piece of data. Now look, if you did not focus on that instantly, and I know some people will say the quote shape of the head, that's not, shape of the head is not a scientific criterion. There are adults who have very small heads, craniums, with very large, brilliant brains, I might add. Do it scientifically. The occipital, the sphenochondrosis, is fantastic for doing that, and it closes in a manner. We've covered that before. Okay, we got to keep moving. All right, so here we go. What did you know? You knew biphasic size population, you knew the histology, you knew the child, you knew the imaging, you knew the history. All right, let's very quickly, Venn diagram model, oncologic diagnosis, overlap the spheres. Very simple one. Let's say you know imaging, age, anatomic location. How old's the patient? 38 years old. Where's the location? Frontal lobe. All right, what's the imaging feature? It shows a T2 flare mismatch in an adult in the frontal lobe. Frontal lobe's IDH mutant disease. T2 flare's IDH mutant disease, 38 years old. This is the diagnosis in the overlap, right in the middle, the black triangle. That is diffuse astrocytoma IDH mutant. All right, let's make it bigger. The way it should be, the full, it's actually 8 spheres. I've just shown one in green, a full sphere. Overlap the 8 data spheres. That will give you the diagnosis in most cases. The diagnosis is in the octagon. I like the octagon, as a metaphor for MMA, mixed martial arts, in the octagon, the cage. That's where we do battle every day as diagnostic radiologists, oncologic neuropathologists. All right, and so this is the 8-sphere Venn diagram model diagnosis. I created it. If you use it, pay me $10 or something, okay? Honor system. Age, gender, clinical history, anatomic location, imaging characteristics, histology, differentiating markers, molecular signature. All right, what initial data did I give you? How many can fill in? Just from the MR, we had the age of child, all right, from what it was. We have the clinical history. We have the anatomic location. We have the imaging characteristics, all right? Child, dramatic response to treatment, cellular pituitary stalk, hypothalamus. That was the critical part of the imaging, right? It wasn't just a cellular pituitary lesion. It was coming up through the stalk and sort of heading posteriorly into the hypothalamus. And CSF dissemination from the from the imaging again, and then dramatic response to treatments from the imaging. All right, final data. Final data, I would argue we also have the differentiation marker and the molecular signature. I'm going to go ahead and call OCT34 as both a differentiation marker and a molecular signature. I think it does double duty, so I'm going to claim that. All right, so here's what we have all of the data. We have 7 of the 8 Venn diagram spheres, and honest to goodness, that's more than you get. We always strive to get all 8. That is the safest for you. It's the safest for the patient, right? We try to get all 8, but 7, this is great. This is what you strive for. That's the point of this. Don't be satisfied with anything less than getting data in all if you have the capability of getting it. All right, and that's plenty. There we go. We are done and done. Germinoma, absolutely. Germinoma, right? That is the way that modern diagnostic medicine should work for every patient, whether you are the primary care treating physician or the diagnostic oncologic radiologist or the surgical pathologist. We should all speak the same language. We should all be looking for all of these Venn diagram series of data, putting them together to help be a safety net for each other, because everyone can miss one thing, and we all have our areas of expertise, right? Okay, very quickly, germinoma, CNS germ cell tumors, 3 big categories: germinoma and non-seminomatous germ cell tumors, embryonal carcinoma, yolk sac, choriocarcinoma, teratoma. Teratoma, we can subdivide into mature, immature, teratoma malignant transformation, mixed germ cell tumor. These are the 3 big categories, all right? Only germinoma and teratoma are very common as pure germ cell tumors, very common. All of the other subtypes, yolk sac, chorio, etc., commonly arise together with other elements, and the 2 most common elements for those guys to mix with are going to be germinoma and or teratomas, and then we call it mixed germ cell tumor. Now note, all right, listen up, mixed germ cell tumors that have a teratoma as one of the components will not melt away to nothing with response to radiotherapy, chemotherapy, radiotherapy, as a system of surveillance image studies, because mature teratoma is not going to melt away. So maybe you have a tumor that's, well, let's say it's a big one, it's like 3.5 centimeters of presentation. Maybe it goes down to 1 centimeter. Still 1 centimeter, that's going to be the teratoma. So with surveillance image, it doesn't melt away. Suspect that it's mixed germ cell tumor, the teratoma component. The initial biopsy, the serum levels may say it's choriocarcinoma, that sort of thing, but it's a non-representative biopsy, small biopsy, et cetera. Serum levels are reflecting chorio, but the teratoma is not seen by the serum level or by the biopsy. Everybody understand that? This is going to make you an experienced clinician and help your team if you remember this point. Germ cell markers, SAL4, all right, it's almost universal except for choriocarcinoma. It stains all the germ cell tumors. There's OCT4 or OCT34, the terminologies are fungible, same thing. CD117 or c-KIT, beautiful strong marker. PLAT, placental alcohol phosphatase, a horrible marker. I think the only reason to run it is for teaching purposes, quite frankly, to show our trainees how to mutual microphone, someone's
on 30, 31, and 32, and she's already signed out 31 and 32.
Oh, okay. We're hearing talk about signing out cases. I think the problem is, when your mic's open and you're talking. Okay. I'm just going to speak louder. All right. Here's my beautiful practical germ cell tumor markers.
This is the one. That's
okay. Is Ann Kwan co-hosting to mute?
There's one at H&E's, but I haven't.
All right, here we go.
I think the
other one, patient 2, generously shared by Min Wang. Okay, who is Min Wang? You may ask. This is Min Wang, a good friend of mine and an excellent oncologic neuropathologist. Min, as you can see, is with the Clinical Pathology Associates, Dell Seton Medical Center of the University of Texas, where he is Director of Neuropathology Services. I want to call attention that he is a board-certified oncologic neuropathologist. In fact, under Peter Berger, during Dr. Berger's Hopkins era, he has perfect training. All right, and I want to thank Dr. Wang for sharing this case. All right, which WHO codified brain tumor entity was discovered by Dr. Wang? Now, if you're an oncologic neuropathologist and you don't know this, shame on you. Now, I know we have very few oncologic neuropathologists listening to the conference, but there may be more in the future, right? Okay, here it is. Monomorphous angiocentric glioma, a distinctive epileptogenic neoplasm with features of infiltrating astrocytoma and ependymoma, mixing the two. There it is, Dr. Wang. Thank you, Dr. Wang, for bringing this entity to our attention. That is just fantastic. We know a lot about it. It didn't stop there. It continued. We now know that MYB, that MIB, QKI rearrangements are driving angiocentric glioma. But you know what? It began with Min Wang figuring out this entity, putting in the literature. Excellent. All right. Let's go back. Patient number 2. This is from Dr. Wang, 33-year-old male. All right, what's your diagnosis? I'm going to leave it here for just a second till we get a diagnosis. We may run over a little bit in this conference. If you have to leave, that's okay. I totally understand, but I am going to finish this conference. I'm in it for the long run. I'm serious about this business. I know people have obligations. All right, so far I'm not getting a diagnosis. All right, neuroradiologist, come on. You want to give me just so I can say someone recognized what's going on? Okay, I'm getting Virchow Robin spaces. That's very creative. I think our radiologists, I think, have already left. That's okay. Here we go. Okay, here we go. Hang on. This is post-op CT showing intracranial air. Oh, that was mean. That was cruel. Yeah, I know. Okay, fine. Now here's the point. Let's move on. Is there another diagnosis that briefly crossed your mind? Just briefly, just for a second when you were looking at this? I know we got a lot of creative answers coming up. Something just briefly crossed your mind? Just for a femtosecond. I mean, just for a femtosecond. What's a femtosecond? Anybody know what femtosecond is? Probably can't type fast enough to get it in. All right, let's take a very brief digression. I want to talk about going big, and I'll talk about going small. All right, this is metric unit prefixes, standard stuff. You need to know this if you did it before. All right, let's start in the middle. Everyone knows about a megabyte, right? What is the next step up from a megabyte? Going bigger. What's next? What comes after that? All right, I'm not going to drag it out. A terabyte. Sure, it's a terabyte world, right? Fine. What's next? Petabyte. I bet there's some people knew about petabyte. Oh, Dr. Gilbert just said terabyte. All right, that was good. Okay, exabyte. Very good. All right, you like that? Here we go. Exabyte. Zettabyte. What's next after zettabyte? I'll wait just a second for someone to answer what's after zettabyte. Now, see, I can't wait too long, you know, because you're playing like you're waiting for the slow typist, but you're really pulling it up on your smartphone. Am I correct? It's okay. You do whatever you have to do to get the correct diagnosis. All right, it's a yottabyte. A yottabyte. Now, look, it's a yottabyte, not a yottabyte. Okay? There's a difference here. This is Yoda. This is actually Baby Yoda, all right, for those of you who are familiar with The Mandalorian, and he's actually hanging out with me in between seasons till next season comes out. Okay, you want to speak to him, I can arrange an engagement. All right, Yottabyte. Maybe it's yottabyte, but, you know, yottabyte, I think I like yottabyte, okay? All right, 10 to the 24th, that's a really big number, all right? And here it breaks it down, yottabyte to zettabytes, exabytes, petabytes, terabytes, gigabyte, megabyte, kilobyte, all the way down to bytes, nibbles, and bits. All right, and here's a nice diagram that shows all of those equivalencies for all the big numbers. I'm gonna give you 1 second to commit it to memory. Got it? Okay, moving on. All right, what about going small? All right, here's the prefixes. All right, going small. Decicenta, millimicro, nanopico, femto, atto. So ATTO, 10 to the minus 18. That's as small as this table from Wikipedia goes. Can we get smaller? Let's talk about chemistry, an attomole. Is there a unit smaller? Molar entity smaller than an attomole? Anybody know? Here we go. Okay, good. Yes, it's a femtomole. That's 10 to the minus 15. Then the attomole, I'm sorry, we're starting with femtomole. I started with femtomole because I said, did another diagnosis cross your mind for a femtosecond, correct? All right, so I started with 15, 10 to the minus 15, femto, then atto. All right, what's next? All right, zepto. All right, you want to try the next one? I'll give a second. Quick second. Anyone wants to type in? Okay, fine. What I'm really doing is letting my voice rest for just a second. All right, it's a yocto. And you say, yeah, I knew that. I knew it was a yocto, 10 to the minus 24. All right, here we go. Wikipedia, going big. Decahectakilo, megagigatera, peta, exa, zeta, yoda. Going small. Decicenta, millimicro, nanopico, femto, atto, zepto, yocto. All right, and look at all these. This is such a great table. All right, it gives you names for all of these: billion, trillion, quadrillion, quintillion, sextillion, septillion, or you could also call septillion a quadrillion, thousand, trillion. How do you like? Isn't that just crazy stuff? Now you know. Same thing for going small: billion, trillion, quadrillion, quintillion, septillion. I can't even say it anymore. Moving on. Wikipedia. All right, I just thought this was kind of cool symmetry. Look at the Y and Z for going big, zeta, yoda, for going small, zepto, yocto. There's some cosmic symmetry to that, don't you think? All right, end of the not so brief digression. Is there another diagnosis that briefly crossed your mind? I don't, just for a femtosecond, was it this one? Do you see how those look just a little bit similar? Yeah, a bunch of black dots on the CT scan. Yeah, just for a second. Cysticercosis maybe, tinea solium, Wikipedia. All right, New England Journal of Medicine, right? Images in clinical medicine. Well, that's not what you're going to get. That's what cysticercosis looks like on imaging. What does it look like histopathologically? Well, in pathology textbooks, what do you see cysticercosis in textbooks? Oh, this is what you get. Is that beautiful or what? And this is an MD Anderson case. Yes, and we did get this, and that's fantastic, but that's not the challenge. There would be no pathologist if all the cases were this easy. That's not what you're going to get. Let's ask the question again. What does cysticercosis look like histopathologically in real life? What you're going to get, not the 1% of the time, the 99% of the time, it's not going to be this. It's going to be this, but there's the stereotactic biopsy needle. That's what you get. That is what you get. And this is going to be the critical part. It's a tiny fraction of that. Okay, and there, see the rectangle lower left? That is the only part that is meaningful. That is why I stress attention to detail. All right, and you're going to have to recognize that as a little bit of this foldy, wavy part of the worm. Everything else is going to be fibrogen, collagen, inflammatory cells, reactive glia, all of that. And you're going to, and because the worm will have died, and that is what elicited the inflammatory reaction, and it's been dying, necrosing, falling apart for days, if not weeks. And then the surgeon goes in to get it, and this is what you get, or a fraction of this with all the inflammatory tissue. Got it? Attention to detail. Have I made the diagnosis on something that, yes, I've done it many times because I speak the language, and you will too if you study it. All right. Okay, guess what? I'm sorry. I'm so sorry. You're not going to get this either for the imaging cupcake. This is what you're going to get. It's going to be a solitary lesion, and it's going to be in a patient that has no history of travel to an endemic area, no suspicion that it could be cysticercosis at all. Do you see a scolax, little bump? I don't know, maybe, not convincing. This sort of patient ends up in the cancer hospital or the general hospital with a cancer diagnosis. And they go in, they take it out, and you'll be lucky to get this. You'll be lucky to get this. Keep the lessons in mind. This is what you're going to get along with a lot of inflammation and stuff, right? But that wavy fold, with the lamina, the layers, all right, and the tiny little nuclei, even if they're going out, it is enough to make the diagnosis if you've seen it before. All right, let's get back to our patient. All right, let's move. Let's look at the resection histology of our current patient. All right, think about what the differential diagnosis is and what the pre-op imaging looks like for the entity at the top of your differential. All right, what kind of specimen is this? What type of surgical specimen we're looking at? You don't have to type. Yeah, this is going to be cavitational ultrasonic surgical exploration. Yes, Dr. Gilbert typed it in. CUSA, C-U-S-A. CUSA's trademark, Caviton's trademark. The process of cavitational ultrasonic surgical aspiration is not trademarked. What's an alternative to the CUSA, the brand name instrument? Sonopet is another common, et cetera. All right, we got to be careful with CUSA specimens. That's why it's important to recognize pseudonecrosis, yada, yada, yada. All right, here's the histology. Take a look. I want you to be thinking. Let me give you a hint. That post-op was just a freak thing that I wanted to show you with the air bubbles. Eliminate that from your mind, okay? Just think about the histology. What do you think the diagnosis is? And then I want you to predict what the imaging looked like, what the real imaging, the pre-op imaging looked like, okay? All right, you seeing this? All right, let's go some more. Okay, and here, I'm moving fairly quick because of the lateness of the hour. Everybody taking it in? If you have any ideas what the diagnosis is, feel free to use the chat function. There's another one. Any ideas? Any ideas? I'm about to show you an immunostain, so that's all the H&E. All right, here's GFAP. It is a glioma. Okay. Dr. Bediven, DDT. Okay, I'm liking that. Let's go back. Let me just tell you just a little bit what I'm seeing here. What I'm seeing here, the first thing that comes to mind is myxoid tumor. I see myxoid microcysts everywhere. Myxoid microcysts. I'm dealing with myxoid microcysts. I'm thinking of all the chordoid things, all the different chordoid things it could be, chordoid glioma, chordoid meningioma, et cetera, et cetera. I'm seeing a mucin cuff right in the center of the field. There is a mucin cuff around a blood vessel. See all the mucin surrounding this? Okay, and it's a glial neoplasm, regular, round to oval, bland nuclei. All right, got it, GFAP, higher power GFAP. Okay, this is the post-op. All right, what about the pre-op? What do you think it looked like? Do you want to see it? The answer is yes, you want to see it. Based on histology, do you have an image in mind what it's going to look like? Is this what you thought it would look like? Myxopapillary ependymoma? It is a myxopapillary ependymoma. It is. But this is actually 8 different patients, MD Anderson cancer patients, showing you a nice spectrum of myxopapillary ependymoma, lumbar cistern, right? Nice. This is not our patient's imaging morphology. The diagnosis is myxopapillary ependymoma, but this is not it. This is not the imaging. Would you like to see the imaging? Yes, you would. This is it. Okay, that's why all the air bubbles were supratentorial, right? Or infiltratorial, supratentorial. That's why they were not spinal, et cetera, et cetera. All right, because this is big craniotomy. This is a tumor that's filling the 4th ventricle. It's T1 contrast T2. All right, notice I kind of like this. If you look at the middle panel, see that vessel in the center? There's several dots, one longitudinal vessel. We absolutely had that on the histology. We can explain it. All right, this is myxopapillary ependymoma of the 4th ventricle. Look, here's the point of this case. The point of the case is if you did not know that myxopapillary ependymoma can occur outside the lumbar cistern, then now you do. Now, does it have the same prognosis, treatment, yada, 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 yada? It is unknown. There aren't enough cases to know that, but histologically, that's what it is. In the literature, of course, it's in the literature. Don't make these things up. All right. Myxopapillary ependymoma of the 4th ventricle. Look, these are all the cases of intracranial, not spinal, not lumbar cistern, but intracranial myxopapillary ependymoma, going back to what, 1983. All right, going all the way forward there. So you should know. I just want you to know it exists. All right, now that's a quick segue. Is there anything new about myxopapillary ependymoma in the forthcoming WHO CNS5? Oh, yes, there is. For example, classical lumbar cistern myxopapillary ependymoma, WHO grade 2, not 1, grade 2. Yes, because of its behavior. All right, it's frequently out of the box, slow mobility, hard to get rid of. Now, this provides us a perfect segue to the big news of the week. This was a segment I introduced when C-Impact Update 6 was released, and I said I really didn't know if there was going to be any more big news of the week for who knows how long. Guess what? We have more big news of the week. C-Impact Now Update 7 was just released 2 weeks ago. Yes, what is it? Advancing the molecular classification of ependymal tumors. I think, honestly, this will be the last. I know I said that about the Update 7, but I forgot that the working group 2 was still doing its work, and here's their report, just under the wire. All right, here it is. Brain pathology, June 5th, just released. There's the PMID. And I'm gonna boil the paper down. You can read the whole thing for yourself. 8 bullet point recommendations in one table. Let's go through them very quickly. Ependymoma should be classified by anatomic site and by molecular group or an associated genetic alteration, so classification can reflect biology. Supratentorial ST ependymoma should be classified according to the gene C11orf95. Now that's the REL-A. So we talked about REL-A, all right, in the 2 updates before. C11orf95 is a more reproducible partner, and it partners more consistently with other partners than REL-A. We're going to make it C11orf95 fine. REL-A, C11orf is the single most common combination, all right, and YAP1 is the other partner. They contribute most pathogenic gene fusions to each of the 2 categories, okay? Posterior fossa, PF ependymoma, should be classified according to 2 most prevalent molecular groups, PFA and PFB. Now that's pediatric type PFA and adult type PFB. They've kind of dropped this group, dropped the pediatric type, adult type, just go PFA, PFB. That's fine. We were already talking about those, weren't we? It was part of our definitions, our discussions. All right, spinal cord ependymomas with MYC-in amplification, which are bad actors, more aggressive actors, should be recognized as a distinctive subtype with a poor outcome. All right, they do exist. Meaningful data related to outcome of patients on clinical trials are not yet available for a WHO grade to be assigned to types of ependymoma defined by molecular alteration. What? All right, let me make sure I got this straight. If it is a C11orf95 fusion, or a YAP1 fusion, or a posterior fossa, or a PFA, or a PFB, or MYC-in, we're not going to give it a grade. Is that correct? Is that what that bullet says? Yes, that is what that bullet said. It speaks for itself, it stands for itself. I think it is generally accepted that the PFAs and the REL-As, which we'll now call C11orf95, do behave in general worse but it's felt that we need more data to be precise about a 2, a 3, etc. Okay? All right? The rare subependymomas could continue to be identified by morphologic criteria, no utility in molecularly substratifying it. Thank goodness. The subependymomas, supratentorial, infratentorial, and spinal cord subependymomas are diagnosed in H&E. It's just subependymoma W grade 1. All right, here's the one we just mentioned. All right, the spinal cord myxopapillary, notice spinal cord, all right, not fourth ventricle, we don't have enough data. Spinal cord myxopapillary ependymoma should continue to be identified with morphologic criteria, but will be designated W grade 2 because clinical trial data sets do not support a W grade 1 clinical behavior. We debated this. We debated this in Heidelberg, what was it, 5 years ago, and considered doing it for the WHO 2016. It didn't happen. I think it's going to happen now. All right, morphologic subtypes of classic ependymoma, papillary clear cell tentative, which are formally codified right now, WHO 2016, should be recognized as distinctive patterns in the description, in the histologic, in the path description, or in the comment, but they should no longer have a formal subset, a formal separate designation. It's a histologic pattern. I actually like this because there are several additional morphologic patterns other than papillary, clear cell, and tentacytic, which like these three do not have clinical utility, but the pathologist needs to be able to recognize them to get the right diagnosis. And we will talk about all of those, which are only briefly mentioned in one sentence in W 2016 in a forthcoming session. All right, and here's the table. Recommended, this is basic recommended classification. All right, let's walk through it. Notice 4 categories: supratentorial ependymomas, posterior fossa ependymomas, spinal ependymomas, and then the separate category of myxopapillary and subependymoma, other. All right, now let's look at the names, recommended suggested names. This could change of the fusions. So C11orf95 fusion positive, YAP1 fusion positive, PFA, PFB, MICN amplified. All right. Now, the statement is there in the table. Sufficient data are currently unavailable for a WHO grade to be assigned to molecularly defined ependymomas. All right, check out all those. Look under WHO grade. All right, sound of crickets. Crickets in the night. Yes, that is the proposal. Now, again, all this could change. These are recommendations, all right, to the greater body that will be creating the WHO5. All right, and then finally, myxopapillary ependymomas, by definition, in the lumbar cistern, the classical are grade 2. Maybe the fourth ventral or grade 2, maybe they're grade 1. I don't think we have enough data to know, okay? Subependymomas, histologically defined, grade 1. All right, now, NB, all right? Nota bene, observe carefully, take special notice, call attention to this. The C-Impact Now updates, like we just covered, update 7, were designed to provide practical guidance on molecular issues in the interval between the revised 4th edition WHO 2016 and the forthcoming CNS5E. They are not the WHO CNS5E. So this update is not the bottom absolute final end, correct? That's why it's called C-Impact Now, not official World Health Organization. That's what the now means, to clarify. All right, the working groups for all the chapters in the forthcoming volume are currently actively engaged in lively evidence-based debate. Okay, I'm a member of one of those groups, and there is a lot of very healthy debate going on by the experts in exactly how to phrase, how to subdivide, etc. Okay, so the bottom line is the final WHO version, when it comes out by the end of this year, may vary in specifics from what we have been discussing and what are in the CF Now updates. That is true, but the updates are the best guide, the best indicator that you have, that we have right now, as to the major changes that are coming. And it is huge for you to have that head start, and you know what the issues are, what the considerations are, and whatever comes out will probably be mostly minor tweaking of what your mind is now prepared for. Okay, and with that, it's 14 minutes. I finished less than 15 minutes under the hour. Thank you for all of those who stayed. Follow me on Twitter, all right? Baby Yoda says, follow me on Twitter, and we'll let that be it. Thank you very much. It was a pleasure having you. Thank you for staying.